Thank you so much for the invitation to speak today during this amazing prevention seminar for SCCT. There has been a lot of discussion and talk regarding plaque analysis, and so many questions arise from how do we use this plaque analysis for our patients and what's the data behind it. This is based off of the DECIDE Registry, and we're going to give you insight into the plaque analysis. So my disclosures are as follows. When we talk about coronary CT and the HeartFlow platform, we are increasingly utilizing coronary CT because it's been implemented not just in the US, but also in the European guidelines. When we talk about the advantages of FFRCT, it helps give us additional information. Does our patient need to go to the cath lab, or do they need medical management? But when we're talking about the plaque analysis, that we are actually informing medical management for our patients. So this adds another layer onto all the benefits of coronary CT. What we know from Scott Hart, there are a large proportion of patients, both women as well as men, who have non-obstructive coronary artery disease. And throughout the CONFIRM registry, we know that non-obstructive disease clinically does matter, where we start to have events downstream in the 4 to 5 year mark whenever patients have that non-obstructive disease. However, we also know that one of the reasons that CT has been increasingly used is because we are starting these preventive medications more often with CT compared to the standard of care, which is nuclear stress testing. This is a very interesting study which actually highlights that about a third of patients who actually have an intermediate to high ASCVD risk with non-obstructive disease are actually not on a statin, which is fairly alarming. And when we look at the GOLD registry, which is a US registry, we're looking at patients who have the highest risk, those with clinical events such as stroke or those who have acquired revascularization. And this registry is actually looking at real-world management of lipids within the United States. And what they found is that 2/3 of our highest risk patients have an LDL which is persistently greater than 70. Now, the Santorini registry is in Europe, and again, they found very similar findings where 73% of those patients were missing their LDL target. And when you look at the details of their findings, one of the things that they felt was important for why the LDL goals were not sufficiently implemented was because of inadequate risk classification, but also underutilization of those combination therapies. And I want to pause a minute here because this is clinically very relevant when we're looking at that plaque analysis. So number one, when we're talking about inadequate risk classification, what the plaque analysis does is it personalizes their risk by looking at the patient's own plaque burden. The other item includes underutilization of the combination therapies, but what we are trying to highlight with our management recommendations is which combination therapies may actually be beneficial. So the primary care physician can know, the referring cardiologist can know as well. In order to have really good personalized results and adequate outcomes, we first have to have a very accurate product. And when we look at the REVEAL Plaque study, it was a blinded multi-center trial where we compared the coronary CT plaque volumes to the IVUS, which is the gold standard. And what we found is that there is excellent correlation with the total plaque volume, but also the calcified and non-calcified plaque volumes as well. And this is all very clinically relevant. We also have plaque nomograms, which are important because, again, we need to personalize these results on both a gender level as well as age. This percentile may be different from your calcium score because we're dealing with symptomatic patients. When we look at certain outcomes trials, I think the combination of FFR and plaque analysis is very important. So when you look at patients who have an FFR CT, which is negative, and their plaque is a lower percentile, you tend not to have any events. But when you start to have an FFRCT that is negative, but your plaque is over the 75th percentile, what happens is that you start to have events later in that 3 to 5 year range. When you have an FFRCT that is positive, however, what you tend to have are very early events. But even when you go to the cath lab to fix that FFR that's positive, and you say to your patient, you've been stented, you've been revascularized, you just need to continue medical therapy, it's still very important to look at the plaque volume, because how we frame our response to patients can be very important downstream for them. Because when you have a plaque analysis that's a very high percentile, such as over the 75th percentile, not only do you have events early on, but you have that combination of events 3 to 5 years later. So in this particular patient, you would want to say to them, yes, we fixed this lesion that needs revascularized. However, you're still at risk downstream. So it's very important to follow with your cardiologist for aggressive preventive care. The next step was, how did we really utilize these studies? How do we utilize them clinically? And we looked at the DECIDE trial, and it was 3 preventive-oriented cardiologists who were also level 3 CT trained. And we looked at a clinical report, and then we decided on what medical management we would choose by the Friedman paper. And as you can see, we most often chose stage 2 medical therapy, which was an aspirin and high-intensity statin. And then we were unblinded to the plaque, and we saw the plaque, and then we said, are we going to de-intensify therapy? Are we going to maintain it? Or are we going to intensify it? And what we found was fairly alarming, in that, number one, the clinical CT reports really didn't articulate well the overall plaque burden of the individual patients. And sometimes seeing that non-calcified plaque or plaque in a very proximal location really changed how we wanted to treat our patients, which would be more intensification of therapy. And 2 out of 3 patients actually received a refined management plan following this physician review. This also gave us information on how we would teach other people how to use this, and actually helped give us some fundamental learning tools to decide how we were going to look at the different arms in the DECIDE registry. Now, I'm only going to comment on one arm of the DECIDE registry, which is very exciting, but what we had are symptomatic patients over 900, and we had this CT performed, and we looked at the physician management or provider management over the first 90 days. Then we performed the plaque analysis, and then we followed any medical management changes over the next 90 days. And again, we looked at changes, and again, we are going to look at clinical outcomes as well. Once we chose the sites, we showed them how to use this severity staging and standard medical management recommendations. And what you're going to find is that we looked at different stages based off of the total plaque volume, which was 1 to 100 mild, greater than 100 to 250 was moderate, greater than 250 to 750 was severe, and greater than 750 was extensive. And then we chose lipid biomarker thresholds and goals, such as LDL, non-HDL, and ApoB, which correlated with their overall risk when you looked at the lipid guidelines. And then we chose prescription options. And what you can see here is we're highlighting all of the different combinations of therapy that may be potentially useful for that patient. And as you can see here, we highlight lifestyle modification, as well as GLP-1s if your BMI was over 27. But then we said, okay, if you're more than the 50th percentile based off of that nomogram, or you have risk enhancers, which are maybe CT, clinical, or biomarker, which are presented in the 2019 prevention guidelines, you may want to go to the second stage of therapy or intensify. And this is very similar to what the National Lipid Association recommends. So if you have an elevated Lp(a) or family history, or maybe have conditions specific to women, you may want to go from that moderate stage by the total plaque volume down to the severe stage when you're making your recommendations. It's important to note that these plaque volume stages have been recently validated by the Fish and Chips Registry. And what you can see here is that for every higher total plaque volume-based stage, there is a statistically significant higher event rate. And this remains significant even after adjustment for age, sex, and risk factors. When we look at the DECIDE registry, we see a very diverse patient population with 50% women, and most of these patients were experiencing typical angina. When we look at the DECIDE registry and the CT characteristics, they are quite interesting in that more than 50% of these patients actually had non-obstructive disease. But the overall total plaque volume for this patient population was quite high at over 300, which is associated with a higher risk of an event. When we look at the DECIDE plaque staging, what you're also going to see is that mild had 25% of the patients, moderate 27% of the patients, severe was 16, and an alarming 32% of the patients actually had extensive plaque volume. So what were the outcomes? What did we do with these patients with their medical management? So if we look at that primary endpoint of the DECIDE registry, 51% of the participants actually had a change in their clinical therapy. 13.9% had new lab orders, 36% had treatment escalation. Very few of the patients had further studies or treatment de-escalation, and 0.5% were referred to a specialist. When we look at change in management across subgroups, what we found is that there was really no significant difference when you look at age, the gender, or the ethnicity, or the BMI. You may have seen a slight difference when we were looking at more severe stenosis or potentially at some of the risk factors. However, what is really interesting is we knew about all of these factors when the CT results were dictated, but really the plaque analysis still helped drive some clinical action with these patients. When we look at change in patient management and we're looking at just the total plaque volume, you see a clear escalation in therapy as the plaque volume increases, which is what we would like to expect when we're seeing research. When we look at the DECIDE plaque stage, remember that's when you can go to the next stage of therapy. It was even a more predominant stair-step algorithm with extensive plaque volume changes up to 67.8%. This is what I always love to see, are what kind of medication changes were made. When we look at the changes in medications, we are definitively predominantly using more statin therapy or intensification of therapy. But what you are also seeing is 11% of those patients had more cardiometabolic disease modification with diabetes medications such as GLP-1s and SGLT2s or triglyceride-lowering medications. You're also seeing more aggressive anti-anginal therapy as well as some additional blood pressure control medications. We saw a distinct difference in the change in lipid concentrations, where the patient management group had a lower LDL of approximately negative 18 milligrams per deciliter and non-HDL reduction of negative 17 milligrams per deciliter. So what does all of this clinically mean when we're looking at our cardiovascular endpoints? We know from all of the lipid-lowering trials that a lower LDL is associated with downstream cardiovascular risk reduction. For instance, a 40 milligram per deciliter decrease in your LDL has a very known downstream effect of 20% lower cardiovascular risk. When we look at all of these changes, from this amount of LDL reduction, one could expect a decrease in cardiovascular risk of nearly 15%. We've clearly shown you today that coronary CT can improve prevention therapy prescriptions. But I think when we talk about where plaque is important, it's important to note these two things. When we look at this Scott Hart 2 sub-study, what we see is that when you look at risk assessment tools, less than 10% versus more than 10%, you see really no significant change in your LDL cholesterol. Yet when you go to a CT-based strategy and you're looking at the presence of plaque, it does drive clinical change, where you can actually see a substantial or significant decrease in LDL when you see the presence of atheroma. What we saw in the DECIDE registry is it takes this a step further, where even after we see the coronary CT and presence of atheroma, we're still seeing a titration of medical therapy, especially as the plaque volume continues to increase. So how do we use this in a clinical case? So this is a 52-year-old male who has cardiovascular risk factors. He's only on simvastatin 20. His EKG is normal. He has intermittent chest pain, which is possibly cardiac. It occurred at rest, and he had the chest pain with left arm pain after playing hockey. His blood pressure is uncontrolled. When you look at his lipid profile, he has an elevated LDL cholesterol as well as triglycerides that are present with borderline prediabetes. When we look at his coronary CT angiogram, what you see is a very complex proximal to mid LAD stenosis. And when you look at the plaque, there is some high-risk plaque features that are present. The FFRCT was negative for lesion-specific ischemia. It was read as a severe stenosis with plaque burden of P2 to P3. When you look at the plaque analysis, you can actually see the very diffuse nature of the RCA plaque, but also in this proximal to mid LAD, you can see the location of that plaque very well, which is very meaningful whenever you have this type of plaque volume. And you can see that the yellow indicates non-calcified, whereas the blue represents calcified plaque. And again, it correlates very well across the board. So when we look at this patient's individual plaque, he has a total plaque volume of over 600. His non-calcified plaque is 85%. You have to remember the 80%, 20% rule. So 80% is normal for non-calcified plaque and 20% for calcified plaque. So this patient has more non-calcified plaque than what would be expected. Even though his low attenuation plaque is not at that 4% threshold that we think is meaningful by Michelle Williams' study with Scott Hart, the majority of his is actually located in that complex LAD, which could be clinically meaningful. So when we're just looking at that total plaque volume, he's in a severe plaque volume stage with a goal LDL of less than 55. However, given the type of plaque that he has, the fact that he had persistently high triglycerides, as well as family history, you would likely go to that extensive stage of therapy. So this patient later presented with persistent chest pain 6 weeks later, and they did a left heart catheterization. What we found is very similar results with an invasive FFR, which was negative, and he had IVUS evaluation. And this is very clinically meaningful for people who may be hesitant. Is the plaque volume really accurate? What you can see is compared to this IVUS, it correlates extremely well. Again, the yellow being non-calcified and the blue being calcified, and you can actually see these rings correlate quite well. So how does our management change based off of the plaque analysis? It's important to go back to everything that we just showed you. So you can see this patient has proximal location with very complex plaque. He has an LDL and triglycerides that are elevated. At a minimum, he would be in the severe stage. Based off of his triglycerides as well as family history, his goal LDL probably is as low as reasonably possible when you go to the extensive stage. So we did maximize his statin therapy, which would probably lower his cholesterol by an additional 5 to 10% because he was already on simvastatin 20. We added Zetia, which is going to lower the cholesterol by another 20 to 30%, but his LDL was still above 70, and therefore PCSK9 inhibitor was added, which can offer another 50 to 60% reduction. His blood pressure therapy was also intensified and aspirin added, and a focus on all of his diet and exercise regimen. and it was felt that his chest pain was musculoskeletal from hockey. So when we go to how can we go beyond just the prescriptive therapies from the physician standpoint, but how can we really combat the things from patients? When we looked at the prior registries that I discussed, what we found is that the patient's reality is they really didn't understand or were unaware of their cardiovascular risk or their reasons for being on lipid lowering therapy, and they did not know what their current LDL levels were or their treatment goals. So when we look at the plaque analysis, I actually have the cards with those treatment management recommendations with me, and I show patients that card and where they are, as well as their plaque images. So then they can actually see and understand their CAD burden because they're seeing the plaque. Then they can understand why these therapies are important because they decrease the risk of heart attack and stroke. And then we can show them what their targets and goals are in a very patient-specific way. Because when we look at all of this patient reality, it highlights an education gap, which, if addressed, could improve not only shared decision-making, but also treatment adherence. And we can see how these types of analysis could help downstream. So when we look at the DECIDE registry, what did we find? We found that more than 50% had a change in their medical management. 45% of the patients with non-obstructive disease had a change in management. I remember I said a third of those patients from one study were not even on a statin at all. Downstream, we would expect about a 15% decrease in risk of cardiac events based upon that LDL reduction and the lipid lowering trials. We will collect our data going forward for our own outcomes for the DECIDE registry, but this is how that was calculated. And why is this meaningful is when we do look at studies such as this UK study, what we see is that CT-directed therapy, when you use CT, you're going to see a decrease in mortality. But when you look at past data and what our reactionary therapy is doing, you see a progressive rise in the mortality. But when you look at behavioral and metabolic risk and how we change that, you could see a potential decrease in mortality by this Lancet Commission, where we're really predicting an 82% decrease by 2050. So all of this is exciting. And what we are trying to do is really change from just focusing on ischemia and obstruction to a lifelong systemic disease where we're modifying therapy lifelong, where we're looking at early detection, plaque development, and prevention, and changing from reactive care to proactive risk reduction. And I think that because you're attending this symposium, you're well on your way to this journey. Thank you very much.